by discussion, development of forms and mentors, has all brainstorming and long discussions and development of web pages, how to execute. Then the team was decided. The team was decided as 25 centers was decided, and data entry collection start, and the trauma has this study has become operational. So this is how, these are the mentors. We are proud that one of the mentor is Dr. Natarajan, is from India, and Rupesh is the principal investigator, and these are the centers. India has got 8 centers in this. And this is the core team of principal investigators. The form is very much detailed, elaborated form, which is online on, and these forms were filled up by all the centers. But that this was the retrospective, and we have some preliminary result. So these are the results about the contributing sites, and then we have a descriptive result about the what is the presentation time following injury in hours, age, gender, race, and eye. We found only 2% trauma were bilateral. These are the circumstances of injury, like location. It is common. Home and workplace are still very common, we found. And object of injury, sharp injury, and body object were common here. BCVA at the presentation was very important. As we see, there are various categories, but it is important that no light perception was 10%. This is the list of patients with no light perception. RAPD again was not described in previous findings, but RAPD only 4.67% were having RAPD, and 4% were having reverse RAPD. These were the clinical findings. Iris trauma was there in 50% of cases. Distribution of patient with scleral injury was 40%. In zone 3 injury, 12%. Patient corneal injury was 80%. Out of that, central axis was covering in 48% cases. And patients on basis of antechamber was affected in 84% cases. Endophthalmitis was very less, 3.3%. And posterior segment trauma was 24%. IOFB was 2%. And adnexal injury was 24%. IGETS 1A was the survey regarding centers who are doing the total number is 33 center. Here we see the type of institution. Majority was were the teaching institution. Majority was the tertiary care, but important is other. Here major is the private setting rather than government. Looking at the practicing pattern of the centers, anterior, it was divided into anterior and posterior segment, including and excluding orbits. This is a distribution. Important question was, does your hospital have a dedicated ocular trauma team? 26 center had a dedicated ocular trauma team. And another question giving us the data about the primary eye repair, how many per year, and how often OTS is used for prognostication. Practicing pattern, when we look at in infected cases, 17 centers were operating in dedicated infected theater. Remaining 13 were doing as a last case and then cleaning the theater. And 69% centers were operating 24/7. Only 31% was during the office hours, 8 AM to 8 PM. Consultant were delegating the primary repair to the registrars or postgraduates only in 33% cases, and only 15% were independent, remaining all were supervised. Delayed presentation was also present in all the centers, and these are the percentage of delayed presentation. Surgical consideration, I think 86% were the general anesthesia, and suture material for scleral laceration was mainly 7080 Vicryl. Then about the zone 3 injury and scleral tear, 35% centers have never disinserted the muscle. Remaining them are sometimes or always. And these are the centers where cryopexy was done after zone 3 injury. In severe trauma and no perception of light, 16% centers were having practice to do the to operate the case and not doing the primary enucleation. In surgical consideration about the traumatic cataract, I think there is a distribution 12 and 20. Some people do in primary sitting and some people do in secondary sitting. And intraocular lens insertion also there are various thinkings. In case of iris and uveal tissue, 50-50%, either iris was reposited or excised, discarded, and in case of iridodialysis, 21 centers repair was done in second sitting. The IGETS-2 is the prospective study, and this just has begun again with the same philosophy with factors, execution, mentors, team, and operationalization. Thank you very much, and we invite you all for World Congress of Ocular Trauma at Delhi during 14-15 December 2019. Thank you.
Thank you very much, Dr. Mehul. I think this is a very important study, and there is a lot of things which will emerge out of it. I was just thinking, that if we have a region-wise analysis, because the kind of trauma coming in India will be different, the kind of trauma in other countries. So lots of things will emerge out of it, and we will be able to know only after the analysis. And thank you very much for the presentation. As and when we have large number of cases, it will be much, much more relevant, and not only to our region, but it will be to the entire world. Because I don't think so far there is any other study in the world. So this will be very significant. Thank you for your presentation. Thanks a lot. I think Dr. Ashok was busy. I think were you having lunch or something?
Got to the other
Lost,
side.
yeah.
Hall G was not there.
So that's what
took
I was.
10 minutes to understand that Hall G is from this entrance.
That's what Ganga was also saying. So no problem. So you are there.
Thank you, Professor Azad, Professor Shukla, and Ganga. It's very nice to begin with Mehul's talk, which gives such a huge context of a very large center in ophthalmic trauma, where we get an idea of what kind of problems we are facing. So I'm grateful to APOTS Scientific Committee for having given me this opportunity to speak on the trends in ophthalmic trauma. We all know the global scenario and how important eye injuries are, but the figures speak for themselves. 55 million eye injuries causing restriction for more than a day. 750,000 cases requiring hospitalization, and 200,000 with open globe injuries in the globe every year. So this is a huge figure, 1.6 million ocular trauma-related blindness globally, and 2.3 million with bilateral low vision. So these are huge figures, and it just awakens us to the need of more focused effort in this field. To add to this is the WHO global data, where it was shown that trauma has not been taken as a cause for visual impairment, and it is clubbed with the miscellaneous. And therefore, WHO mentions in its own document that injuries have been low in priority for policymakers. But this needs to be corrected. So, more particularly focusing on what we know about ocular trauma in India, we're going to look at 4 things. How common is trauma here from whatever figures we can get? What is the pattern of this trauma? Where does the trauma occur? Because that will be important for deriving our strategy for managing and tackling it, what we need to do. So let's look at what we know. There are 2 major studies. One is the Andhra Pradesh eye disease study and the Adven comprehensive eye survey, where they talk about injuries being present in 7.5% of population in this survey of South India, and unilateral blindness to trauma in 0.6%, which is huge figure. Then Adven study also says that lifetime prevalence of ocular trauma. Somebody has had an ocular trauma of significance at some point in his time, almost 1 in every 20 persons. More figures. A survey by Watts et al., 2.5% prevalence in urban population, almost 1/10 of them lose vision. And the National Statistical Organization related data, both for urban and rural, the figures are alarmingly significant, almost 5% here as well. Looking at the pattern of ocular trauma or ophthalmic trauma, as Ganga corrected me, the most important things are that young people are involved, more than 50% being 25 years of age. Males, as we all know from all figures, involved almost 3.5 times more than others. And road accidents constituting more than 1/3, sports and recreation another 1/3, then occupation. Now this is the figure from this tertiary hospital. And in a hospital-based data, open globe injuries are almost 3/4. Another figures about the pediatric ocular trauma. Here again, male-female preponderance. Again, the causes here change to some of the sports, including bow and arrows in our country, wooden stick injuries, which include gulli danda, fist and fingernail, and then again the preponderance of open globe injuries in the data from the hospitals. Now, where is the trauma occurring and what can we do about that? We have the workplace-related trauma, domestic ocular trauma, road traffic trauma, sports and leisure-related, and combat-related. So what about the workplace-related trauma? Again, no national data available, no reporting system exists, but we know that it is most common in the young adults, and that is why the preponderance in young people. And it constituted 56% of the eye injuries in Andhra Pradesh study. And in urban study, 46.9% were agricultural labor related. So we know that workplace related is possibly the most important one and also occurs in construction sector and the manufacturing sector. So domestic trauma, again, we have very little data because there's no organized sector here involved, and it is second only to work-related trauma. Road traffic injuries are becoming more and more important because of the lack of traffic discipline that we have in our country, and this is something that can be tackled by a more emphasis on discipline. Sports and leisure related, this is again an area where education can work a lot, because there is hardly any use of eye protective devices except organized sports like cricket and hockey. And we have a huge plethora of injuries due to firecrackers, tir kaman, gulli danda, where again we can do a lot by education, by legislative action. Last thing, what do we need to do once we know that whatever little we know, there is a need for, of course, a lot more in collecting the data. That is the one single most important thing, and I think IGATES and all these, the recent effort at collecting the data regarding firecracker injuries are all great initiatives by Asia Pacific Ocular Trauma Society, and they would help us a lot. So there are registries which exist for American Society, International Society of Ocular Trauma, OTSI, and APOTS initiative. But this is one area where we need to be working very hard. Ocular Trauma Society had started this initiative. We've been working on this. Let's hope it can take off in a big way. So the data suggests that 90% of all eye injuries are preventable. And for us, the policy formulation has only just begun in 2011. And occupational health policy was one of the components of the national health policy which started in this year. So this is an area which will need to grow, but where our initiative and our advocacy will be very important in gaining anything. We also need to work hard at public education, special groups for workmen, for leisure related, sports related, and for combat related as well can work very well. Legislative steps are essential. Here again, Inputs from society like Asia Pacific and the national societies will be very important. And in industries and armed forces, these need to be regulated rather well. And we even lack disability definitions. Recently, there have been some work on this and compensation law regulations, which we need to work on. So targeted education for all these groups will be very important, which we have a role to play in. There has been no visible campaign to educate public so far, which is of any significance, and that really is where we all will have to come in with advocacy, both at public level and at government level. We need to sensitize governments. We need to help create publicity materials so that we are able to achieve what we want to. And also, there are a lot of things that we can do. We need to recognize it as a distinct subspecialty, need to work to create curricula, to develop the subspecialties in individual hospitals so that it can be taken up by the regulatory bodies. Education during residency training needs to improve. Subspecialty fellowship programs will follow once this is done. And better interspecialty coordination and management is a huge area, and for that an adequate infrastructure will need to exist. And this infrastructure has to be at the primary management level and at the secondary and tertiary level. So this is again a huge area where we have a lot to do, and there certainly are miles and miles to go for us. We are just beginning the effort. Let's do it with all our might so that we achieve something. And like Mehul, I would like you to invite to the World Congress in December 14 and 15 at the Le Méridien in New Delhi. Look forward to all of you being there. This will be one area where I thought APOTS and OTSI will get together and will become a huge platform for us to take things forward. Thank you very much. Thank you again for the opportunity.
Thank you, Ashok, for very rightly you put that we need to have some data, as IGATES are already doing it. So once we have a data, we can impress upon the, the policy makers and the leaders, who can really help us. And just now Ganga was asking me about the, starting a fellowship certification for ocular trauma also. I think Purnendu had written me long back. Yeah, it is there. Yes. So ocular trauma, no, I'm not talking about, I'm talking about certification. Certification, we can do the certification. I think you did write a letter to me, Purnendu, about the fellowship of the All India Collegium, we are giving FICO. So you had written me a letter regarding that, but maybe because of oversight now the Ganga told me, so I thought that, I need to know how many places fellowship programs are there on ocular trauma. So if I have those centers, then, Dr. Mehul, if you can help me out, then we can have the exam this year only. I'll have the meeting of the board, and yes, but not combined with ICO, because ICO may not agree. For ocular trauma, for others they have agreed. But for ocular trauma, it will take some time, isn't it, Ashok?
Yes. We need to make a beginning.
Beginning, yes. We will make a beginning, and then later, once we are under sound footing, then maybe, we can do that also. Thank you so much.
Actually, the challenge now for OTSI is to get us a deliverable by the time we have our meeting in December. How about that? Let's take it as a challenge. We'll have an update on this by December. Thank you.
So may I now invite Rajiv, I think he's speaking on pediatric ocular trauma. Rajiv?
While Rajiv is setting it up, all of you manage trauma, I suppose, so that's the reason why you're all here with some special interest as well. Just show of hands, how many of you are general ophthalmologists? Just show of hands. Good, very good. We're all general ophthalmologists to begin with. Right, first, okay. We're ophthalmologists first. Second, how many of you are anterior segment people? 1, 2, 3, 4, 5, 6. Okay, 6. Okay, very good. How many of you are posterior segment people? 1, 2, 3, 4. Okay. How many of you are oculoplastics? 1, 2, 3, 4. Good. So we have a reasonable distribution amongst all the specialties. How many of you work with other specialties routinely in the management of trauma? Good. Same 4, 5, 6, actually more for this, which is a good sign. Rajiv, on to you. Thank you.
Thank you.
Point out that I think Rajiv was the organizer of the last Ophthalmic Trauma Congress, which was held in July in India, in Chennai. Was one of the most successful trauma congresses in the history of ophthalmology in India. I would dare say that. And I think that's a good sign for ophthalmic trauma, and I think we're going to take it even further forward. Rajiv.
Inspiration from that to work for our conference.
Yes.
Thank you, sir. It's a real pleasure to talk about a very important topic of pediatric ocular trauma. And the topic given was medical and economic consequences. Are we doing enough? And actually, the answer was very clear, no, we are not doing enough. So I could have finished it one slide, but I thought let me gather some of the information which is there globally present and which can help us. So ocular trauma in children is common, so varying reports from 20 to 59% of trauma occur in children. And again, it's a little different group with a poor outcome. That's probably the visual immaturity. There are increased years of visual compromise. There's a potential for amblyopia. So definitely we see this group with a poor outcome. And it's been again reported that severe visual impairment or blindness seen as nearly 12 to 14% in these children who have ocular trauma. So I thought I can cover in 3 headings: legislation and policies, education, and personal eye protection, what we have done and what can be done. So in many of the developed countries, there have been now medications and household cleaning products. They have child-resistant packing, and sometimes I'm sure you must have struggled opening a bottle for your grandpa. These are become real difficult ones, and in India, still it is yet to come. We still have many of these medication coming in these bottles, which expose, there is a risk of chemical injury, and that's something which can be done. Again, as very rightly Dr. Grover said, that it's the bow and arrow injuries which are very common in an Indian scenario. And there are laws. In Australia, they have rules of warning signals are there, and there's supervision and age appropriateness is there. Europe has got standards for toys, and there are standard safety things that if the kinetic energy of a toy is more than 0.08 joules, they come into a separate category where a separate age group only can use it. I think these are the things which in India has to be adopted. Again, just to re-emphasize the bow and arrow injury, this was during the time of Mahabharata, where we had published our data of 233 bow and arrow injuries, and nearly 1/3 of them were inoperable. I think that is important, and the overall success rate in spite of multiple surgeries was about 62% functional and about 85% anatomical success. And again, we had more of male preponderance, and it was the broken arrow tip which was retained in the eye, and that this was published, and this was way back 10 years back, and today still the situation is same. So I think what sir, you were telling that you should create evidence. Evidence is there, but somehow we could not translate it to a legislature. Firework, again, a very important factor, and 1 in 6 firework related ocular trauma is associated with severe vision loss. Again, more of male preponderance, and one factor which more and more we see in our population is the bystanders. So nearly half of the injuries are in the bystanders who are not participating in the firework play. And the countries which have got a restriction on firearms and they have a legislation at place, the ocular trauma incidence is 0.35 in 100,000, as compared to countries where the restriction is not there, it's 2.7. So that's something we come in this down one. If we have these restrictions, last couple of years there have been selected regions in India having a government legislature, and we need to get this statistics that how it has reduced. In sports, again, one of the thing which I found is in boxing, there are now gloveless, gloves, the thumbless gloves, so that has reduced corneal aberration. So I think Like these, some of the interventions need to be done. We have been mainly focusing on cricket and hockey, but there are, over last few years, we are one of the world champion in boxing too. So we are getting more of sports related. Though traffic related injuries, we are more concerned about the other parts, but there are reports of about 17% of them having 17 per 100,000 having ocular injury when there is a road traffic accident. And those places where they have the seat belt compulsory, the incidence has reduced. Again, airway related, this was related to the airbags. So airbags related injury are also more common, and that's also has been reported in literature. So what needs to be done? That's the question which we had. We need to have laws regarding drug packaging, laws regarding safety of toys. Again, a very typical injury seen more in India is the packed line, the tuna. And we had the ocular surface meeting where there was all the institutes, major institutes from India, giving a memorandum to Government of India to ban these packed line. But I don't think after that anything has happened, and I think it's again, as a society, we need to take some action and put it to all the bureaucrats. And laws related to ocular safety. Education is very crucial, and this is one of a very good example, a published article from Israel, where on their Independence Day celebration, they use artificial snow, which causes a lot of corneal damage. And they reported in 2007, on that day, they had 87 injuries. Then they created awareness. Before the next one, they had a TV advertisement, newspaper, media, and they had just leavenized the very next year. So this does show that if we use media in creating awareness, it can really show an impact. There are websites, and this is one of the websites, I Play Safe. For kids now, and nowadays the newer generation are more tech savvy. I think again we need to create these type of platform with our Indian toys, how you can prevent injuries, and use that as one of the ways of creating education. Regarding protective eyeglasses, there are a lot of regulations in various other countries. We need to see this very strictly implemented in our country too. I'll give you a very simple example. One of the things which I feel can be done is occupational optometry, which is very much developed at Shankaretrale now. And you go to Mahabalipuram, and you will be happy to see all of them wear the side covered glasses. And because there are a lot of these people who make all the statues there, and they have very common ocular injury. So last 1 year we have been working with all the people there, and now if you go and see, and you see that side covered, I think that is something, a simple measure which can that has reduced accidents in Mahabalipuram. I think that's the way we need to think of, and then not a major project, it's a small scale industry, unorganized sector. We need to just go on a locality wise and tackle this. So again, are we doing enough? No, definitely we need to take lessons from global evidences. Lot of evidence are there where how intervention, education or a legislation has changed the incidence of trauma. We have all the leaders here, and I think the next is creating advocacy to all the bureaucrats so that these can be translated to laws. And I'm sure OTSI and APOTS has got a major role to play in this. Thank you very much. I would like again for 2 meetings. One is in July we are having a Retina Summit. This time the theme is Pediatric Retina, and definitely looking forward for the World Congress of Ocular Trauma. And as rightly we thought that it would be nice if we have some very clear, even 1 or 2 points which we can take to the government and create advocacy. Thank you very much.
Thank you, Rajiv, for covering the topic very, very well. Yeah, you're leaving, is it? Both of you? Okay. But thanks a lot for coming, but we'll be in touch with you all. Yeah, very good. Now, really touching on an invaluable part, because I think what 40% of the Indian population is pediatric.
Yes.
Is it 40%?
Yes.
And with you're talking about statistics of about 0.2% going blind.
Yes.
That's a significant number for a population of 1.3 billion actually going forward. It impacts not just the individual but their families, the educational capabilities, the professional aspirations, and economically, finally, it does affect that as well. So I think I'm glad we are talking about it. You're right, we're not talking enough about advocacy because the data is there, but how many of us, in our own practices, we have brochures on phacoemulsification, laser phacoemulsification, but in the pediatric office, what strabismus is there, is there even one flyer or poster on preventing this eye injury in a child? It can be even seasonal based. Just before month before Deepavali, you can have these simple flyers in your clinic so the parents become aware that children are exposed to these kind of injuries on a regular basis. I'm really thankful, and I think we should probably continue to work on it. That's where I think OTSI should take the lead and make it work with either AIOS or independently. Work with top-notch institutions first, centers of excellence, both private and public sector. Set the example, which eventually the smaller practices will take off. Thank you, Rajiv. Yeah. It's my pleasure now to invite Dr. Purendra Basin, an inspiring force behind ocular trauma work in India. And he's been a great supporter of trauma-related education and meetings. And we are now going to take it to the next level towards advocacy. Thankfully, we are starting to see some good results, and he's going to give us an update on Firework-related ophthalmic trauma. Yeah, Dr. Purendra.
Thank you, APOTS chairpersons, and especially Dr. Gangadhar Sundar for giving me this opportunity to give you the insight on firework-related injuries. And I was just listening to all the talks. Dr. Rajiv has already covered part of it, and he has emphasized on how important this part is. And firework-related injuries are a big number, and they are more common during special season or during the festival purposes. So these injuries are, fireworks are used worldwide for the festive purposes during the New Year Eve globally, and especially in our country during Diwali, Independence Day in USA, and all the important days throughout in the various part of the world during their special occasions. So unfortunately, this has been associated with various bodily injuries and permanent disabilities and even death. Ocular trauma contributes to whopping 16 to 31% as per the various studies of total number of firework injuries. And firework trauma are a serious public concern as they predominantly affect young males, which are in their productive age group. And there are severe, devastating, and permanent effects on vision, cosmesis, and professional functioning. They can be so devastating and damaging, and irreparable loss could be there, as you can see in two of these injuries which we can have from our center, which we could not do much. And there is a large corneoscleral tear extending to the periphery up to the root of the muscles and beyond, and we could repair it, but unfortunately we could not save the eye because of the extensive damage in the posterior segment as well. Another case with the large tear, another case which could be managed. It takes long time to manage such cases, but ultimately if you can save it, the effort and the energy used during to maintain it is really heartening and welcome, we feel. But many a times it is so devastating and damaging that there is a tissue loss and loss to the posterior segment, optic nerve, adnexal trauma, and even if we can manage it for a few months, the later period of life, it is you are not sure whether it is of good, we can give useful vision to that patient. Literature review says that in this study which was published in British Medical Journal, wherein they have reviewed 26 articles for calculation of trauma incidence and patient demographics. Out of these 26 articles, 17 were reviewed to assess the trauma severity and vision loss. 77% injured were male, 82% young, and 47% bystanders, means almost 50% were bystanders out of this. Most of the trauma was mild and temporary, and penetrating eye trauma, globe contusions, burns accounted for 18%. Enucleation rate was hopping 3.9%, so much. And mean visual acuity was more than 10 by 20 is 56.8%, and severe vision loss less than 10 by 200 in 16.4%. Another study which was from US only, and out of 327 patients who had body trauma, the 100 patients were of ocular fireworks injury. 41% were younger than 18, and the 54% were within 48 hours of 4th July, that is the Independence Day of US. So this is what it is, the status, and this was 11 years of firework injury study at level 1 trauma center. Another study during from the another part, that is China, clinical analysis of firework related ocular injuries during Spring Festival in 2009, and similar results were there. Observed 25 eyes in 24 patients. Injuries were more frequent in children, males, and open globe injury was 62.5%. More common in rural residents. More common injuries were corneal, scleral, corneoscleral, open globe trauma, that is 60%, traumatic cataract, vitreous hemorrhage, retinal detachment. And the visual outcome showed statistically significant improvement. Initial best corrected vision correlated strongly with final best corrected visual acuity. So then when this talk was allocated to me, I studied, because recently we had Diwali festival in our country. So we studied retrospectively the fireworks injury in just 4 days of Diwali at our center in 2017 and 18. And we analyzed, and we found that 85% of them, we received 20 patients in 2 years, 12 in 2017 and 8 in 2018, in just 4 days of ocular trauma with the cracker blast injury or the firework injury, and 85% of them were less than 20 years of age, and they were mostly males. And variety of cases were there involving lid adnexa, anterior segment and posterior segment. And the final visual outcome, what we can see, was not very welcoming and very not very encouraging to us, because in almost 35% of these patients we had vision in the category of blindness less than 360 or even no PL. In one patient where we have eviscerated the eye. This is an unusual case which we could retrieve the can I video can you So this was a case with the firecracker injury, blast injury, and the child had a foreign body which was embedded in the pars plana. Can we come out of this and see the video, although it was functioning there? So we could then we could find it out by the UVM, and then we planned out with along with the vitreoretina surgeon, the anterior segment surgeon, we did a cataract surgery and central capsular axis. Then we made a posterior capsular axis and did a limited anterior vitrectomy. Is it playing? हाँ, इसमें ऊपर रखिए ना, ऊपर blue वाले में. No, yeah, this one. So we removed the foreign body from the pars plana by doing a limited anterior vitrectomy and held it with the intravitreal forceps, and then we removed it through the paracentesis wound or the main wound. If it is okay, if it is not working, we'll go ahead. foreign body removal, this one, second one. Can you make it full screen? Oh, I think we can skip it. It's fine? Okay. Yeah. So, this is the foreign body which we, after doing limited anterior vitrectomy, we held it with the intravitreal forceps. Then we did a vitrectomy again with the vitrector bimanual way, so that there should not be any traction. And we removed it through the same wound. It was, the thing is that in these firecrackers, I don't know how they embed these metallic particles. How they have come, whether it is a potash or something, or some mineral particle, metallic particle. They are fine metallic particles. Okay. Then another case which I remember, we operated 2 years back. He had a firecracker. He is a policeman. So he was a policeman. He had a bilateral firecracker injury. For 3 months he remained bilaterally blind. He could not see because only PLPR was there, because there was a involvement of adnexa, the lids, then the corneoscleral wound, melting of the cornea. We did twice we did keratoplasty in one eye, and in the other eye we did a patch graft. And after this patch graft and the glue, when as our previous speaker was saying, that our corneal wound should be made secured first. Then we planned for the intravitreal surgery, and there were a lot of potash particles inside the eye, and but we could manage this patient. In one eye, the vision we could retrieve after 6 surgery in that particular eye, and the vision was 6/9, and the other eye there is a 3/60 vision after the whole half of the retina has been damaged by this. And the important thing which my previous speaker, Dr. Raman, also emphasized, that legislation has got a role in this. In this study, which was published in BJO, wherein they said out of these 13 studies where there were restrictive legislation law, the incidence was less, and in permissive legislation where there was people were allowed to do the firecracker injury without taking any help from the professional persons, there the incidence was very, very high. So to conclude, there are now improved implants, where the better grafting techniques and inclusion of navigational techniques in oculoplastic surgery, this has improved the outcomes in the adnexal firework injury. And a timely referral of the patient to the tertiary center after primary care can salvage some eyes. And a multidisciplinary approach should be adopted to maintain normal anatomy and physiology, and we should go for a stage surgery and improve the anatomy and physiology of the adnexa, ocular surface, cornea, glaucoma, lens, and retina. In case of no hope, measures should be taken to improve cosmetically by appropriate prosthetic devices, so that the patient's psychology is not affected. Firework-related ocular injuries occur mainly in children, males, and are frequently severe and visually devastating. 50% of firework-related ocular injury decreased following a ban of bottle rockets. And in 4 states in the United States which have banned the sales of all fireworks, and these states have a lower rate of firework-related injury. And this was found to be, the banning of the fireworks was found to be more effective than public education in reducing the incidence of injury. And there should be a strict and restrictive laws on personal use of fireworks for the safety of person handling the fireworks and spectators as well. And we as Trauma Society, welcome sir, and APOTS, Ocular Trauma Society of India, and World Ophthalmic Society should collectively work to ban all fireworks except the supervised public display in all countries. And I invite you to the World Congress of Ocular Trauma, which is going to held in December 14 and 15 in New Delhi, and it will be really an experience. Please, you all should involve actively by sending your papers, your experiences, and participating it. Thank you. Thank you.
Thank you, Dr. Basan. Yeah, a comment.
Ah. Oh. Okay.
Patients who came to us during that 1 month with firecracker.
So these are just in 4 days we have seen so many
Yeah.
patients, and retrospectively long-term patients who come from elsewhere, they come in 15 days or 1 month period when they come for the tertiary care. And this is something which I really appreciate Dr. Ganga for bringing this to the notice of everybody and emphasizing it. And what we do at our center, that during Diwali period, we give the preventive advertisement in the local newspaper, how to protect your eyes. In a small way, we do it from our charitable organization. And I think that we can pass on, and local language we can circulate in various states.
Thank you, thank you. While you're stepping down, and Professor Azad, I think we have the greatest honor of having Dr. Azad as not only the founding president of the society, but a president emeritus, in the sense that his contributions to ophthalmology in India and the region and globally has been immense. And I think he's now taken it upon himself to try to take ophthalmic trauma, ocular trauma management, and now to prevention to even greater heights. But can I ask you, Purendra and Rajiv, we know now there are laws by the central government. Then I don't know how much of it has been translated into reality. Since this new law has come in, I was told that even the pollution rate during that time has gone down a little bit, the side benefits. Have you noticed a trend towards reduction of injuries, just a trend offhand, or you think people are people and they continue to do it? And what do you think is the greatest barrier to this? Is it cultural? Is it religious? Is it enforcement? Is it supervision? Where are we missing the ball? I'll ask both of you. Yeah. Under the microphone. Yeah.
Your question is very relevant and pertinent. I think in this last year ban in Delhi, they have seen, even the All India Institute has seen less number of trauma patients in their OPD during this period of Diwali. And in our center also, last year we received 12, this year we received 8. And we did see the trend of decrease because of one thing, that was the ban by the legislative law. And secondly, what you are saying is, what you want to know is that what is the barrier for this? What I feel is that education and advocacy. I think we can go through various local societies, social societies like Rotary Club, Lions Club, and ask them to and educate them, various societies in the local group, and through them we can give this education that how to protect, because we see a lot of patients, and this is only ocular what we are seeing. It involves the whole body, and that is what it is devastating. And I feel that it is definitely the only thing which is going to help us is by banning and we can ban specific kind of the fireworks like rockets and the kind of dangerous kind of bombs which are, and local bombs should be they should be banned. At least this will decrease by 50%. And the children should be not be allowed to do the play with the fireworks, and if at all, then it should be with under supervision by the elders. With that only
Thank you.
we should do.
Thank you. Yeah, that kind of leads us to Professor Azad's talk on advocacy. Then we'll continue the discussion.
No, I
Yeah,
think
perfect. Yeah.
What you were discussing, it is related to what I am going to talk. And basically, as you rightly said, now it's not that there is no awareness. No, the awareness is there. Like, the National Health Policy, as Grover Ashok was, presenting, National Health Policy, ocular trauma has been included. Similarly, like, in Delhi, firecrackers, in Diwali and all that, there is a, kind of a cap that after 10 o'clock you can't this thing, and also the amount of decibel, how much sound you can make during these festivals and all that. That portion is on decrease, but the other things are on increase. Like ocular trauma is on increase because of we have so many industries are there. If you go in some remote areas, you come from Gwalior, and also places like Gorakhpur, or places like some other places in Bihar where the workers are there, like welding, somebody is doing welding, is not wearing any kind of protective equipment. So many other similar kind of profession is there where people are not aware, and the people who are employing them, they are not interested in that. So all these things are making a very complex situation. Now we have this this terrorism is there. Now I think Natarajan, he'll say that, he went to Kashmir and he did a lot of surgeries on ocular, retina and ocular trauma. So these things are, keeping this ocular trauma at a very, critical stage. Like road rage, there's a lot of the young people, they are coming and, with hot brain, and they start fighting, So all these things creating problem. And then regional issues, what we were talking now about the cultural issues like festivals, bow and arrow injuries there. Of course, now all these things have come down because of the, I was associated with National Society of Prevention of Blindness for a very long time. And we had those posters, I think Purnendra must be knowing about that because he was also associated with that. So those things are there. But on the other side, we still need to do very much. Now, as I told you that it is now getting recognition. Now, I think you must have all seen that in all the states now, they have focus on trauma, not ocular trauma. Trauma is a general. You will see the trauma centers like we have in AIMS. So something like this, it is being duplicated in the entire country. Trauma centers are there. But specifically ocular trauma, I think we need to emphasize with the government that even where you are having an ocular, a trauma center, there should be a separate wing for ocular trauma also. Because ocular trauma is a specific and a very, exclusive kind of specialty where you need to have kind of training facilities, you need to have the management facilities in terms of equipments and other things. And then, still we need to have a very concerted effort, as everybody said, that we need to have a kind of a very strong advocacy. We all speak here, but then when we go back, we all get into our patients and our job. But then if we consider that this is also our job and a part of the job, say if 25% of our energy, if we have to put towards this, then definitely it will be very successful, which is very difficult. But then, for a cause, you can definitely work. I think what we need to, why ocular trauma is important? The trauma is important because it is if you don't take care of this, there'll be a compromised workforce. People who are young, people who are exposed to this, trauma, they are the ones, who are suffering and who are a loss to the workforce of the country. And that, causes decrease in the GDP, the national growth rate and the national workforce. And this, causes workforce pressure on the other people whose number is limited because of the problems associated with their colleagues. So we all know that we need to aware, people who are making the policy and the peers. Like we discussed that we can, I'll just tell you, we can make a universal advocacy document. A document or a charter which says that for these reasons, the ocular trauma is more important than any other trauma. I will not say head trauma, because head trauma, of course, if somebody has got a head trauma, he's gone. But then ocular trauma also holds a very important position in the entire gamuts of ophthalmology. And then, we need to have industrial law for safety of workers. I was talking about the welding and similar kind of jobs. There are a lot of jobs, even wo jo, kya naam hai, ye, what you call as a chiseling. So those kind of small, the work is there where people are totally exposed. And there it is there, and there is no kind of, no regulation or nothing of that kind, or protective devices are there, but they are not distributed, or people are not aware about it. So those things are there. And the most important, what we were talking about, that we need to have a collect data. If we collect the data and we put it in the right perspective and put it in the universal advocacy document and say, look, sir, as I think who presented, Rajiv presented, that 0.3% was when the firecracker ban was there in those countries. And countries where no firecracker ban is there, this 2.7%, it makes a huge difference. You extrapolate this on the total population of India. How much is 0.35% and how much is 2.7%? So it's a huge difference if we can make, if you can just simply write this thing, and then we can simply write that so much of blindness is there and so much pressure is on the workforce of the country, and so much is dip in the GDP is there, then people will understand. Now everybody is talking about growth rate. The country, the different parties, they are saying them, our government, this is the growth rate. But this is our party. So we should talk about our party, what our party needs. So we need to, work together and do it. And then on the operational side, Ocular Trauma Society should connect with the people through posters, hoardings, and banners. The banners should be there, just like polio, 3 bund polio ke. So usi tarah se, if we can put it up, on the back of the bus or the bus stand. So we need to talk to the people who are doing CSR, corporate houses. If we talk to the corporate houses and tell them, look, you take care of the posters on the bus. Or we can talk to some other people, like lots of other agencies are there, government agencies are there. So they will help, even the railways. So I think it's a huge job, We can't just sit in this room and we talk and then we go, that's what we do. I mean, frankly, we should admit, because of our, engagement in, our own profession. So that is very important. And then, of course, you can give an interview, or some news should be there in the electronic media or the print media, or something, some kind of do's and don'ts. So if we put it in the newspaper, so I think that will be very helpful. And then observe Ocular Trauma Week. So during that week, everybody works on ocular trauma, focuses on prevention of ocular trauma, focuses on awareness, focuses on the training to young ophthalmologists on the management of ocular trauma. I see, the people who come with perforating injury, the thread sutures are there, 40 sutures on the cornea. So people need to be trained, So those things are very important. So I will, request all the people who are here, although it's a small group of people, but I don't think for this we need a very large group of people. So we need to emphasize the need to declare ocular trauma as a priority area by government and also by non-governmental agencies. We can draft a universal advocacy document. And thank you very much. So Natarajan is not, he has gone?
He's run away. He said he promised he'll come back.
He has promised?
So I still have my hopes high, yeah. And it's not 2:55 yet, so he will come actually. But thank you, Dr. Azad. I really appreciate your inspirational words to kind of highlight what can be done, but more importantly, what we have not yet done. And I think that's where the opportunity is. I think it's like a child going to school. If you're already 95, 98% scoring kid, getting that 99 is 100 is very difficult. The child is scoring at 35% level. Actually, it's easy to go from 35 to 50%. Just needs a little extra effort. 35 to 60, 70, yes, a little bit extra more. So in other words, we have a lot more to progress. And I think we should take it upon ourselves as a challenge to change from that low levels to high level. Rajiv, you wanted to make a comment. Come.
Before Rajiv says, I think people, all of us who are sitting here, I need, we need your suggestions, I mean, so those suggestions which are I'll just give you an example. Ganga just now said, we have the attendance of, say, 8,000 delegates in our All India conference. If we just make a kind of a questionnaire, put 10 questions only, that how many cases of ocular trauma you see, and what kind of trauma, what is the object, what is the type of trauma, how much is the damage to the globe. I mean, those things which are very gross, but at the same time, you will get a good information. If I can get suggestions from you, something which is workable, and I think that will be something, without much effort, we'll be able to collect good data. Is it, Ganga?
Yes, we should target by next AIOS. And those of you who are involved in state society meetings and city society meetings, you can start almost immediately. And when that, you start collecting data from, say, Tamil Nadu or Uttar Pradesh, Madhya Pradesh or Rajasthan or whatever it is, that will inspire the national leaders who are organizing these national congresses to start collecting at a total national basis.
Even if we have data for, say, 1,000 people, this is more than enough. Bahut zyada ho jayega.
And I'm now requesting Dr. Azhar personally to invite somebody from the Ministry of Health for our December meeting, by which time we will present the data. If you can even invite one of your trauma patients to come on the day of inauguration and narrate in 5 minutes the trauma, the travail he's gone through and how it has changed his life, hopefully we can get directions from higher leadership. So let's come, Rajiv, you wanted to make a comment.
It was just the question which we had discussed. I think very good points which you have told. And a couple of things people are doing that. Like if a ocular surface, I remember the meeting which they had, they called all the patients with ocular surface injuries, and these were the benefit. They came to the stage and spoke. So I think that is something which would be really good looking at a larger picture. Questionnaires are very good idea. And again, I would say that doing it at regional is much better, because all India thing we hardly get less, 1% of them will reply. But state meetings, it's a best thing.
I'll give you an example how the National Program for Control of Blindness was started in India. Of course, you may not be knowing that I'm talking of 76, 77, when I was a resident in RP Center.
And Rajiv was not even born.
LP Agarwal was the director. Every day he'll come and he'll say that how many blinds are there, how much money you have to put. You know what he said that so many blind people are there and there is so much of loss to the country, and to prevent this blindness is 1/10 less than the cost of the expenses on this blind people. So just simply, you have to make some kind of, statistics you have to put in front of them, and then I think that the things will be accepted.
Questions from people in the audience, so your personal experience in managing it, not from the technical aspect of it. You can ask about sutures and needles, so on and so forth. That is there where all the other sessions are. We are here more to talk about what are the other challenges that we face. Anybody from the audience? Experience regarding your comments? Just come up to the microphone, please. Just identify yourself, your specialty, and where you're from.
One of the fears of also touching such patients.
Right.
In private practice, what happens is if you have a globe injury or a corneal tear, so if you have the patient coming in with 3-4 attenders, and then, so sir, if you touch it, will he be all right? Will he be able to see? That case is probably touching at your point, even if you know it is at times we see that we have an institute wherein he be probably more counseled well to or probably dealt even better, because you have anterior and the posterior guys handling it together. So maybe during our initial trainings, if we've been, more than learning the cataracts, if we really push and, learn more of oculoplasty also, out of interest, right? Rather, we've all been taught cataracts more, and as we grow, we know we want to learn phaco. Of course, then the oculoplasty comes in a little later, not at the initial stages. So maybe during the course, I mean, it should be also, taught us that well upon all the centers of the India.
Yeah, I think your point is very valid. In fact, I criticize my own residency program as well. We are not training graduating ophthalmologists. We're graduating cataract surgeons. And sad to say, with all due respects to cataract surgery, and I still do cataract surgery, we are not training well-rounded ophthalmologists. You have to be. That's why I think we did a survey initially. We're all what specialists, but we are all ophthalmologists first. I think that's why the well-rounded education system should be there. And I think that's why program directors should probably take the lead in saying that, oh, lid trauma, send it to oculoplastics, this, send it to there, whatever it is. But you as a resident, work with the oculoplastic person, take care of the eyelid and the corneal laceration, so on and so forth. I think that has to be there. I don't know, do you still have the trauma unit in Netralia? It was there before. And then what happened?
No, then it became, now it has gone to all speciality. Exactly like you said, orbital goes to orbit, retina goes to retina, but we don't have one.
So I think that's where the conveyor belt philosophy kind of comes in. Should the patient be in one place and then you call the oculoplastic biparsha and come and say I have this patient with fracture and this closed globe injury, versus you go to the oculoplastic clinic there and see biparsha? And I think that's where we have to make that change. And once you have an ocular trauma unit, you have the retina. So we have closing comments from Professor Natarajan, who, by the way, in case you didn't know already, is the president of the Ophthalmic Society, taking over tonight, and has taken it upon himself to put, apart from a lot of other advocacy events, ophthalmic trauma in India and the Asia Pacific and the globe.
Thank you, Ganga. We brought Vasant here. Where is he? Vasant just walked in. Ganga, he's come to meet you. And then we also have Dr. Azim from. Do you see trauma, Dr. Azim? Azim, where is he? Do you see trauma in Borneo? Okay. So Brunei.
Brunei is the richest country, and by the way, they can sponsor all your studies if you want.
So I think ocular blindness due to trauma is largely avoidable through awareness and timely treatment. So I'm part of all this OTA, the Ocular Trauma Society of India, Asia Pacific Ophthalmic Trauma Society, International Society of Ocular Trauma, International Council of Ophthalmology now. We are taking important steps to reduce blindness due to ocular trauma. If you have seen, American Academy does a lot of advocacy for both to the government as well as to the public. And we have created actually the main thing is Azad, as you already told, Dr. Gangadhar Sundar said, under the umbrella of Asia Pacific Ophthalmic Trauma, the team dedicated to set the tone for subspecialty care in the field of ocular trauma and to formulate general guidelines through evidence-based medicine, to build a network and team where I think Rupesh is doing his best for making a registry along with and we also made Indian eye registry many times, and I think it's like many times we have failed, and I gave a talk in the morning to the young ophthalmologists. More you fail, I think more you find a way how to succeed. So right now Rupesh has taken and made eye gates, and where is making an international trauma registry under the International Society of Ocular Trauma as well as Asia Pacific Ophthalmic Trauma Society. Petition to the Ministry of Health and Family Welfare India and supported by the members of APOTS was sent, totally prepared by Dr. Rupesh Agarwal, supported by Gangadhar and Caroline Chi and Professor Azad. But as you know, nothing moves in the government in spite of giving, and I think one of the things which I am working on is to ban crackers in India. Somebody said that Sivagasi, they will come and maybe even kill you. But it's a fact. I think they are producing harm more than benefit, except child labor also goes on there. And more now, I think we have crackers from China more than India. So for a requirement of legislation to mandate the provision of the firecrackers used at households and public places, to limit the use by professionals and at designated places like the US and probably even Singapore, and to use protective eyewear, and children should at all times be accompanied by an adult a minimum distance of 3 meters away from the firecrackers. Unfortunately, firecrackers are used in marriages also.
we had I don't know how inside a marriage hall they had a firecracker, and they actually had a rocket, and it went into the bride's eye, into the almost touching the brain, and then he had a CSF leak, and the neurosurgeon said if you touch him he will die, so better leave it alone, and that eye became tricycle. And this was from times of India. This Diwali you can burst crackers only from 8 p.m. to 10 p.m. for 4 days, but it doesn't, according to me, all these restrictions may not work, because everybody finds a time to do something or break the rules. And I think AOS, APOTS, ISOT, OTSI, all have to come together, and in collaboration with, we have the president of ICO here, and also the vice president and CEO of the ICO here, Dr. Neeru Gupta and Peter Wideman. And I think we have to do something on this global ban on consumer fireworks, which should not be. Consumer fireworks are widespread and available in many countries. Unfortunately, serious injuries related to use of consumer fireworks occur in countries where they are not banned. And even strict regulations on the purchase and use of fireworks do not prevent the high incidence of related eye injuries and the resulting visual impairment and blindness in some patients. The ICO endorses a global ban on consumer fireworks and encourages ICO member societies to advocate for legislation to ban consumer fireworks in their countries. And the position paper was also endorsed by the International Agency for the Prevention of Blindness. But I find, at least in India, we have to work with the minister, and in spite of knowing the minister and making them do is a real problem. And for that we need data to impress them, and probably other ways to go to the public media and mention. And that's why the International Globe and Adnexal Trauma Epidemiology Study, the eye gates, was started by Rupesh Agarwal on behalf of the Asia Pacific Ophthalmic Trauma Society, and we have the Chinese Ocular Trauma Society. And thanks to Gangadhar, who called this ophthalmic, because he says orbit is not being involved otherwise. And Eye Gates Fireworks is a prospective study, and we look into recruiting patients from, which actually recruited patients from November 1st, 2018 till 28th February 2019. And this study will provide extensive data relating to the firecracker, firework injury to the eye and adnexal structures. And this is the Eye Gates fireworks, and plus I think, as Dr. Azad was mentioning before, and where we have to make ocular trauma a very important part, because every subspecialty is involved. And I usually tell the patient the trauma or the disease does not study the book and come. The book comes from the patient. That means we write from the findings and make the book. And another problem in India is we play Holi in high-rise buildings in Mumbai. They throw the balloon filled with something from a high-rise, and in case it lands on the eye, it can make a open globe injury. And if it is straight, it can have a chemical injury. Sometimes they put chemicals inside, or the lime. And I think Shankarnathar had a lot of lime injury, not from Holi, but some other festival in Chennai. So anyhow, I lived in this quarters where like my grandfather was there in 1930s. My father was there from 1955, and I was born in 57, and from that time I lived in the quarters for 12 years. And that's how I've seen that every day there were 100 corneal foreign bodies coming. Somehow I'm seeing ocular trauma from my age of 7 to 8, because I used to put torch for my father. He used to use that, I forgot the name of the needle, which remove the corneal foreign body. It's there in the Parsons book. It's just a blunt needle, but I remember later, when if you don't get the needle, you will use the 23 or 25 gauge from the sterilized needle and remove the corneal foreign body. Hundreds of patients. I was thinking that time somebody should have done advocacy and either told the company, either the factory, you don't do this, because everybody will say, yesterday doing work I had this, and that means a small speck of iron deposits on the cornea, and if they don't go for a day or two, it will get deeply embedded. And I'm sure Azim will remember those days, but I hope the number has changed now. And I think I wanted to say welcome to there's a replica of the Elliott School of Ophthalmology, and the picture of the government eye hospital is there. And there's a beautiful pictures taken by Dr. Syed Arshad, who's an ophthalmologist and oculoplastic surgeon in Saudi Arabia, and is an alumni and plus a classmate of me from MBBS and later in ophthalmology. And this is a rosewood which is banned, which is there still. And we should be proud, because this is the oldest, biggest exclusive museum and the first ophthalmic museum in the world. And there are there's a magnet called giant magnet. I don't know how many of you have heard of it or seen it. Anybody has seen it? Okay, a lot of people have seen it. Good. The giant magnet is really giant. It's such a big one, round one, and in case if you don't remove the speculum and the instrument and you take the giant magnet towards the patient, along with the drape, the entire thing will come, and it has happened in front of us because you forgot and you press the foot switch and then the magnet gets on. And so we are celebrating 200 glorious years of in modern ophthalmology because the first eye hospital was started in 1819. And I also want to tell to Gangadhar, Singapore was found by Raffles in 1819, and that's how. Thank you very much.
Thank you. I think we come to the end of the session. I really appreciate those of you who took the time to come and join. If you have any inputs, let us know. Quick show of hands. How many of you from India? How many of you are members of OTSI? Purendra, Dr. Natarajan, we need to do more.
Yes.
I think it's as simple as that. Less than 10% of, and I'm sure all of you do trauma, right? And sad to say that you're not member of a society. Exactly right. So how do they find information, Dr. Natarajan, to become a member of OTSI?
OTSI.in. www.otsi.in.
Go online. There's a form. The next official scientific congress of OTSI is going to be on the 14th and 15th of December in New Delhi, La Meridian. I'm from Singapore, but I'm inviting you for the conference in New Delhi.
Yes.
By which time you should become members. We're going to start a major advocacy campaign. I've just suggested Dr. Azad, the health minister or health secretary, will be involved in the meeting.
Right.
We will make a big difference. And for that, we ophthalmologists have to gang up against whoever it's necessary to protect our patients. Thank you very much, everybody, for coming.
Thank you.